Hello, my name is David Trimberger, and this is my instructor checkoff attempt for my pediatric direct oral intubation. So the first thing that I want to do is gather up all my materials, such as a suction device, padding, a laryngoscope with a couple different laryngoscope blades also set off to the side in case I need to adjust for sizing, a BVM with a mask, capnography, an OPA, a stabilization device, and then my ET tube ranging from about a 3.5 to a 4.5 for my pediatric patients, as well as my proper PPE. So the first thing that I want to do is put on proper PPE. I'm going to come over, manually open up the airway, inspect for any signs of vomitous secretions or blood. If there is, I am going to suction out the airway by suctioning for no longer than 10 seconds on a zigzag motion on the way out. I'm going to re-inspect the airway. Once my airway is clear, I'm going to measure for a proper OPA. Insert my OPA. Then I'm going to put my patient on a high flow nasal cannula. I'm also going to take my BVM, attach it to a nasal cannula, and then I'm going to ventilate, or also put my patient on an SpO2 monitor. Then I'm going to ventilate at a rate of 10 to 12 times a minute, monitoring for adequate chest rise and fall. Because my goal is I'm trying to pre-oxygenate my patient, so I'm going to be trying to get their SpO2 above 94%. Is to get them to 100%. That way, whenever I am attempting my intubation attempt, they still have enough oxygen going through their system. So after they have been pre-oxygenated, I'm going to prepare for my intubation attempt. So I will remove my OPA, go ahead and attach my BVM to capnography, set up my stylet, my laryngoscope. After I'm all set up, I'm going to come over to my patient. Since they are a pediatric patient, I'm going to pad in between their scapula to try and get their ear to sternum to be more in line. After I've done that, I will come over, displace the tongue, insert my tubing, insert it to the proper depth, inflate my cuff, remove my syringe, remove my stylet, go ahead, connect my capnography to the monitor, attach to my patient, and then I'm going to ventilate at a rate of 10 to 12 times a minute. I'm going to be looking at my capnography and SpO2 to make sure that my patient is getting properly ventilated. I'm going to check to see if there's misting in the tube, and I'm also going to do a secondary confirmation of making sure that I'm in the proper placement of auscultating over both of the lungs as well as the epigastrium. Once I have confirmed my proper placement, then I'm going to stabilize my tubing. And as I was doing all of this, I would be assessing for signs of hypoxia. I'm going to ventilate my patient at a rate of 10 to 12 times a minute, monitoring for adequate chest rise and fall, as well as looking over their SpO2 and capnography. And then I'm going to monitor my patient for any change in patient condition en route to the hospital. Thank you.